So now we're going to move on to a new theme that's going to take us through the rest of the afternoon, and the theme now is going to be patient outcomes. So we're going to start off with a keynote speaker and then move on to some oral presentations. So it gives me great pleasure to welcome here Professor Lonneke van der Pol-Frans. I think it's fair to say that Lonneke is one of the international leaders in the work on quality of life in cancer patients and looking at survivorship issues. She's a professor of cancer epidemiology and survivorship at the Centre for Research on Psychology and Somatic Diseases at Tilburg University, and she's also head of research at the Comprehensive Cancer Centre South in the Netherlands. It was in 2004 that Lonneke was appointed to the Comprehensive Cancer Centre to write a Dutch Cancer Society report on cancer in the Netherlands. In that report, she looked at quality of life data, and that stimulated her interest in this area. Since then, she's done a tremendous amount of research, and a lot of that supported by grants to establish the Profiles Registry and move things from cancer patient registries to cancer patient outcome registries. And Lonneke is going to talk to us about quality of life issues in cancer.
Thank you very much. Thank you for the invitation to present here our studies. I will take these 30 minutes to talk about how we use the cancer registry to do quality of life research, and in fact make it not a cancer registry but make it a cancer patient registry. You've seen this picture a few times more today, so I'll be short about it. This is where we do our studies in the Eindhoven Cancer Registry area, where 2.4 million inhabitants live, and we register cancer in about 10 hospitals and 2 radiotherapy institutes. And on an annual basis, we register about 20,000 new cancer patients per year, including basal cell carcinoma. We're part of the Netherlands Cancer Registry, which has a coverage of about 100%. Traditionally, the Eindhoven Cancer Registry, which started in 1955, registered information like most cancer registries based on the tumor stage and grade, but also on treatment like surgery, radiotherapy, and systemic treatment. Most information we had about the patients was whether it was a woman or a man, and the age at time of diagnosis and date of birth. And we also had socioeconomic status based on their postal code. In more recent decades, we also included survival analysis. Since 1995, Jan Willem Kuberg, who was head of the department first, introduced to register comorbidity at time of cancer diagnosis. So since that time, we register comorbid conditions according to a modified Charlson index. And doing all these traditional cancer registry activities will give you information on incidence and survival, but also on prevalence. And these numbers that I show you here is just to give you an idea of the strong increasing prevalence of cancer in the Netherlands, but these rates are very similar to other Western countries. So for example, if you look at the year 2000, we have, if you take 10 or 20 year prevalence, we have about 400,000 men and women in the Netherlands who were diagnosed in the past 20 years and still alive on January 1, 2000. If we look at 2020, we will have over 900,000 of these patients who had, or survivors, who had cancer in the past 20 years and who are still alive on January 1, 2020. So within 20 years, that's a doubling of the number of cancer survivors. And these doubling numbers are also shown in the US and other countries in Europe. The question that arises from these steep increasing prevalence numbers is, how are these cancer patients doing, in fact, or these survivors? Because in the Netherlands, we have 600,000 today, but in the UK, we have 2 million survivors, and in the US, 12 million. And are these patients cured, or are they living with cancer as a chronic disease, or do they experience long or late effects of having had cancer or the cancer treatment? What are their psychosocial needs? So in sum, how are they doing in the long run? And to illustrate why it's important to assess quality of life, I'd like to start with this example, and I've done this more, so maybe you've heard it before. But this is a question from the gynecologists in our area who were wondering what the value is of doing a routine lymph node dissection in early stage endometrial cancer. And they were really divided in opinion. So half of the gynecologists in our area, say 5 hospitals, were strong believers of doing a lymph node dissection in stage 1 and 2 endometrial cancer. And the other ones said, no, we just give radiotherapy in the presence of risk factors. Well, what would you do traditionally with a cancer registry? You check whether the survival is different, but there was no survival advantage. And then the strong believers of doing a lymph node dissection argued that by giving or by doing lymph node dissection, they would prevent radiotherapy in a large amount of women, because you would only give radiotherapy to those women who had positive lymph nodes. So that's about 9% in our region, compared to 30% who would receive radiotherapy based on their risk factors. So we would prevent radiotherapy in about 20% of the women. And since we know that radiotherapy has long-term effects, they argued, or the hypothesis was that, well, there's no survival advantage, but there must be some quality of life advantage here. So what we did is we asked all the women in our area who survived endometrial cancer stage 1 or 2 how their quality of life was. And here you see that the dark blue bars are the women who received a routine lymph node dissection in these 5 hospitals where they believed in this. And the light blue bars are the women who did not receive a routine lymph node dissection but get radiotherapy in case of risk factors. And you see right away that on all the scales of quality of life, those who received routine lymph node dissection were actually scoring lower, so they had a lower quality of life. I would definitely not say that this is clinically relevant different, but at least the hypothesis that they would have a better quality of life cannot be confirmed by this finding. And if we look at the specific symptoms, the women who received a routine lymph node dissection reported worse body image and also more lymphedema problems and pain in their lower back. So I'm just showing you this because these findings resulted in the fact that the gynecologists in our area decided not to do this lymph node dissection anymore in early stage endometrial cancer, simply because it didn't add any value to your survival, and nor did it in your quality of life. So I always find this a very illustrative example of how doing quality of life research really contributes to the discussion whether a treatment is beneficial or not. So what we do is we use the Eindhoven Cancer Registry for these types of studies simply as a sampling frame, and we select patients based on the research question that we have. So for this study, for example, we selected all women with stage 1 or 2 endometrial cancer who were still alive at the time that we send out the questionnaires. And the questionnaires typically contain questions on socio-demographic variables or lifestyle, such as smoking and alcohol use and physical activity, but also generic quality of life, and we use more and more the QQC30 from the EORTC. We used to use the SF36 for those who are into these types of studies. And in case there is a disease-specific module, we also apply that. And then we quite often also assess whether patients have anxiety or depression problems, fatigue, information provision problems, or return to work and insurance issues. And quite recently we established the Profiel study, which is a profile study in English, and patients can go online after they were invited with a questionnaire to complete the questions. So they get a login code, and in case they do not want to use internet but prefer to complete a paper questionnaire, they can send us back a card and say, no, please send me a paper questionnaire. And even in the Netherlands, where about 95% of the patients have access to the internet, only 40% complete online questionnaires. So most of the patients still prefer to do the paper and pencil questionnaires, and so we give the opportunity to also do that. So this Profiel or Profiles Registry that we now have, the acronym stands for Patient-Reported Outcomes following initial treatment and long-term evaluation of survivorship. It's nothing more than an infrastructure of data collection of patient-reported outcomes, either web-based or pencil and paper. And we link these data with the cancer registry data that we have. And so we have the Profiel study site for patients, but we also have the Profiles Registry site for anyone of you, for example, for researchers who are interested in patient-reported outcome studies. And you can go to this site and you can use the data for free if you're an academic user. So this is the profile study site, and here you can just browse the studies that we're doing. For example, we have some studies on melanoma, colorectal cancer, lymphoma on these on the site. You can also browse the topics if you're interested in quality of life or anxiety, depression or fatigue or whatever you're interested in. Just see whether we collected these data among the different cohorts and in which waves. And we have normative data, and you can just fill out a small form, just say who you are and what you would like to be doing with the data so that we get informed how the data are used, and then you can download the data for free. So we now have a cancer registry plus comorbidity data, plus more recently also patient-reported outcomes. And that gives a wealth of new opportunities to use your cancer registry. So today we have done these analyses in about 15,000 cancer survivors in our area, with all different types of cancers based on different types of questions that arise from clinicians or patients themselves or our own research groups. And they're all financed with money from different institutes. To give you some ideas of the types of study that we're doing, is a recent study that we've done on sexual dysfunction in colon and rectal cancer patients. And we asked almost 1,400 colorectal cancer survivors in our area with a response rate of 82%. And we compared that with 400 age and gender matched control population without cancer. And we asked them both, the norm population and the colorectal cancer survivors, to complete a questionnaire on sexuality subscales of the CR38. And what you see here is that the sexual functioning from men are a little bit lower in the colon and rectal cancer compared to men of the same age without cancer. Sexual enjoyment is quite similar, but mostly the problems arise with erectile functioning, and which has been shown previously among rectal cancer. There's about 50% of the rectal cancer survivors who have erectile dysfunction compared to about 25% of the norm population and 25% in the colon cancer survivors. For female sexual functioning, you see that sexual functioning again is lower compared to the normative population, but also sexual enjoyment is lower compared to women of the same age without cancer. And female sexual problems are typically a dry vagina and pain during intercourse, which is twice as high compared to the normative population. So in conclusion, sexual functioning for this study was deteriorated in both sexes after cancer compared to a normative population without cancer. And lower sexual functioning was associated with higher age at diagnosis, not having a partner, obviously, rectal cancer, female gender, low educational level, but also more psychological issues like depressive symptoms and fatigue. And lower sexual enjoyment was associated again with higher age and female gender, but now again with depressive symptoms and having a cardiovascular disease. Another example, you can also study socioeconomic implications of having had cancer. So recently we published a study on the insurance problems that cancer survivors in the Netherlands face when having survived cancer. And we used a sort of cross-sectional analysis of all the different cohorts that we're following on patient-reported outcomes. And we asked almost 3,000 colorectal cancer, melanoma, and lymphoma patients who are on an average 4.5 years after diagnosis, how they were, if they were asking for or if they were applying for an insurance after their cancer diagnosis and how they were doing with that. And of these 2,800 patients, 586 patients said yes, we tried to obtain a life insurance after cancer, and 20% of them experienced problems by doing so. But if we looked at the more younger group of patients who would definitely have probably tried to do this more often, then you see that almost 60% of them experience problems by trying to get a life insurance. We also asked if they were trying to get a mortgage after cancer diagnosis, and then you see that 1 in 10 experience problems, but among the younger people, it was 1 in 3 of the patients or the survivor who experienced problems. And the findings of our study were reported in a national press in the Netherlands, in one of the largest national newspapers. It said, well, no mortgage or insurance after cancer. And it was then picked up by many newspapers and primetime evening news in the Netherlands. And the good thing about it, I think, is that it led to a national discussion whether this was fair or not. And I think that's also what research is about, that you want to contribute to some sort of national discussion sometimes on, you know, what's going on with, in this situation, cancer survivors after they had survived cancer. And if it's fair or not, if you're 10 years after cancer and you had a melanoma of 0.01 Breslow and you're still not able to get a mortgage, for example. So what happened is that the Netherlands Federation for Cancer Patient Organizations reacted, and then also the Association of Insurance Companies sent some really dirty emails to me that my data were wrong and that they did not confirm these findings and that everything was fine in the Netherlands. But then a month later, in the biggest Dutch newspaper, they said support for cancer survivors. And what happened is that this association of patient organizations and the insurance companies are now joining forces to end discrimination of cancer survivors who want to get a mortgage. I mean, this can be really, yes. Well, you can also be cynical about it. I mean, I think this is good, and we'll have to see in the future what really comes out of this. So it's good to keep monitoring if things are going better. But at least you can really put an effort in trying to get something or get some discussion going on in what survivors may face. And it really helped, even though they were not reacting so nicely to me. So we now have the cancer registry with comorbid data, patient-reported outcomes, and recently, like was said this morning, we also linked with pharmacy data from public and hospital pharmacies in our area with the Pharmo database. And what you now can do is you can evaluate the impact of new, expensive, targeted therapies on quality of life in real-life settings. So, for example, what Joe Selby told us this morning, that you really want to have some information outside randomized clinical trials, that's what you can do with these types of linkages of registrations altogether. And for example, here you can see a study that is now published in Hematologica recently. And you can see that the quality of life of non-Hodgkin survivors and divided in aggressive or indolent survivors is definitely statistically significantly, but also clinically relevant, lower on all subscales of quality of life. And specifically fatigue seems to be very much deteriorated compared to a normative population of the same age and same gender distribution, and also dyspnea and sleeping problems. And since this was a longitudinal study, we could see that the fatigue scores were fairly stable over time. So even if you're 8 to 10 years after diagnosis and also during follow-up, we saw that for the whole group on average, the fatigue scores were twice as high compared to a normative population. So 6 out of 10 non-Hodgkin survivors report a clinically relevant higher fatigue score compared to someone of his or her own age. And this is stable years after diagnosis. Interesting enough, we did not find any clinical parameters that was associated with this. It was mostly your, again, gender and psychological factors that were associated with it. And we're now trying to link the data with the detailed pharmacy data to see if we can find whether specific targeted therapies are associated with this or whether it's more a psychological thing, because it's not really clear from our current analysis yet. So by combining clinical data, comorbid data, and patient-reported outcomes, we're not focusing only on the cancer information anymore. In fact, we're now looking at the cancer patient as a whole. And then we have a cancer patient registration, like I said. And that gives us the opportunity to continuously monitor the impact of cancer and new treatments on long-term outcomes, patient-reported outcomes. Luckily enough, we're not alone by doing so. There are many colleagues here and anywhere else who are doing these types of studies. Many studies are done. Many cancer patient registrations are conducted in northern part of Europe, but also Canada, the US, Australia, and also Japan and China are doing these types of studies. And we have recently performed a systematic review that is now submitted on invitation for a special issue of the journal Cancer, and it's going to be coming out probably the end of this year or beginning or next year, in which we try to evaluate how all these cancer registries are using the cancer registry to do population-based patient-reported outcome studies. And well, I'm talking about patient-reported outcome studies already, but just in short, it's nothing more than an umbrella term, and I think in the UK they more often say PRO measures, prompts. And it can be either symptoms, it can be functioning, health status, psychological well-being, overall health-related quality of life. The most important part is that it's provided by the patient without amendment or interpretation of the doctor or anyone else. And an interesting thing is, and I think that came also clear out of the presentation of Joe Selby this morning, is that it's recognized as a very important, more and more recognized as an important indicator of treatment efficacy. And the FDA, the US FDA, as well as the European Agency for the Evaluation of Medical Products, have now acknowledged the importance of PRO studies and clinical trials, including PROs. And it's also an important tool to assess long-term outcomes of cancer survivors. The advantages of using a cancer registry to do PRO research is that you can include a large number of patients, you have information on socio-demographic and clinical characteristics available, and you are less likely to have problems with referral bias compared to doing a hospital-based study. For example, if you want to investigate the impact of esophageal cancer on quality of life, and you have patients who are referred to all these different hospitals because they are going to get their surgery over there or not in your hospital, you'll have a complete different outcome compared to the other hospital. Whereas if you're active in an area including 10 hospitals who refer to each other, you get a better comprehensive idea of what's going on the long term in a complete area population-based situation, which then also gives you a better external validity of your data. So what can be research aims of using a cancer patient registry is that you can investigate the prevalence of late or long-term effects of cancer and its treatment. You can identify subgroups of patients or survivors who are at increased risk for these effects, or you can identify risk factors for developing these effects, such as lymph node dissection and worse body image or lymphedema problems and how that impacts your quality of life. And then you can use these studies to inform efforts and improve quality of life, stop doing lymph node dissections anymore in early stage endometrial cancer, or even design interventions to improve quality of life. For example, and I'm not going to go into that for now, but based on the studies that we know that the information provision is not so well to the satisfaction of the cancer survivors in our area, we are now doing a randomized trial within the population-based setting to see whether survivorship care plans can improve information provision to patients. So you can use your setting also to conduct new studies. So to go back to the systematic review that we've done, we included all peer-reviewed papers in English that were published between 2001 and 2011, and it had to focus on cancer survivors and be population-based. And it had to use a cancer registry either as a sampling frame or later in a linkage with the PRO data. And the outcome parameters were patient-reported outcomes such as quality of life or health status or symptoms. And we assessed the quality of the study on the information that was provided on the cancer registry procedures and the study design. And altogether we were able to include 166 studies, of which the majority came out of the US, but also the northern part of Europe, like Norway, Sweden, the Netherlands, Germany, and Australia. Most of the cancer patient registries studied breast, colorectal, or prostate cancer. So the most prevalent cancers were again studied in these types of studies, or multiple tumors, which were mostly a combination of the most prevalent tumors. So most of the study focused on adult survivors, but only 3 were really focused on the elderly. 2/3 of the studies were rated of high quality, and most of the methodological shortcomings were that they were either cross-sectional in nature, or there was a lack of information on the follow-up of the vital status, and also treatment data collection from the cancer registry was often not well described. So what we found is that the PRO studies are increasingly conducted from using a cancer registry, and that cancer registries provide important clinical variables and are an excellent sampling frame for doing these types of studies. However, interesting enough, they are not doing the utmost what you can do with these types of studies, because you would expect these types of studies to focus on patients that are not included in clinical trials. But again, we see that most studies focus on the most prevalent cancers and are not including the elderly. So it would be really nice to expand the activities in these cancer patient registries to the types of studies that are not done in a clinical trial setting, because that's, I think, the power of doing these types of studies. And last from this presentation, I would like to share with you the discussion we had ongoing with our colleagues in a Eurocourse meeting, Work Package 6, where other colleagues from other cancer registries were talking with us on how they were doing and what their experiences were in using cancer registries for PRO assessments, and how can we learn from each other. So Volker Arndt was there from Germany, Anne-Marie Bouvier from France, Linda Sharp was there, Penny Wright from the UK, and my colleagues from the Netherlands. And we discussed the variation in ethical issues that there is in Europe, which is large. For example, in the Netherlands, we quite often don't even need an ethics approval to do PRO assessment in patients. And if you do so because you ask about sexual activities or types of issues that are considered invasive for patients, you can have a central ethics assessment, which is similar in the UK and France. But I understood from Linda that here in Ireland you have to have your ethics for each center, and there are many centers. So, and in Germany you can also have an ethical approval from one center, and that will be a sort of master approval. We learned from each other how you get patients to participate, and again, like was said this morning in the presentation by Joe Selby, have patient groups participate in your study questions and the start of your study, and have patients approached by their own treating doctor or formerly treating doctor. Start with cross-sectional studies, that's the most easiest thing to do, and clinicians are sometimes more interested in the short-term effects, so that's a very easy target. Get patients as early as possible, keep track of them, create cohorts. However, as most registries have difficulties in keeping track of patients or including patients very early in the trajectory of diagnosis, because the cancer registries are often completed in a later phase. Penny Wright told us what she did in the EPOCs in the UK is that she would assess patient-reported outcomes first and then link them later on with the cancer registry. So that's another way out. And ideally, it would be so wonderful for these types of studies to have a control population for each country themselves, so that you can compare your survivors with gender and age-matched control populations. And for example, what we do in the Netherlands is that we use the data of economists who are working together in large studies in Europe also, trying to assess economic evaluations and have all these economic panels. And they are now collecting quality of life data for us because they have a normative sample that is so easy for us to assess. So these patients once a year complete the QC30, and we just explain, listen, this is for these and these reasons. So we don't have to create our own sample. And there are so many other groups of researchers who are active in this field, but just with a different subject that you can work together with and try to really easily get these control population data. And then an important thing is, how do you pay for these types of study? Because currently, assessing patient-reported outcomes within the cancer registry as a routine measurement is not feasible. We don't have money for that, and there are simply too many patients to assess all these outcomes. So Germany is tagging this to quality assurance, like Linda also told me, for the evaluation of quality of care or guidelines, you can assess patient-reported outcomes. In the UK, where the holistic needs assessment is quite hot at this moment, they tag it to that. And we also find that it's sometimes easier to fund cost-effectiveness studies, so you can put it in that sort of perspective. And then hopefully in the future it gets easier to get money for patient-reported outcome study. And perhaps PCORI will be a good fund position for us. Because I think that in the future more cancer registries will become a cancer patient registry. So I hope today that I've showed you that using a cancer registration to make a cancer patient registration gives you a situation where you can monitor the impact of treatment on patient-reported outcomes. You can contribute to the discussion on the value of new therapies, but you can also evaluate socioeconomic implications of cancer survivorship. And something I didn't touch upon today, but it's done by our group, but also all the others who are doing these types of research, is you can assess the psychosocial needs of cancer survivors, and you can even conduct interventions or make interventions to improve quality of care and quality of life of cancer survivors. So that in the end, you can have a really comprehensive assessment of cancer survivorship by combining your cancer registry data with other sources of data. Thank you for your information, for your time.
Thanks, Lonica. Oh, is this on? Yep. We've got time for a few questions. There's one down here.
Thank you for your presentation. I was very impressed, and I was also impressed by the participation rates you mentioned for, I think, colorectal cancer. And are these rates similar for other cancers? And if yes, how do you do this?
Yes, we have participation rates between 70 and 80%. And I think an important thing is that most of the patients in our area do not participate in any quality of life study before we ask them. We don't have an academic center in our area. I think that's quite of an advantage for these types of studies. So they didn't complete 10 other questionnaires before. And a major thing I really believe in, but that's for our situation in the Netherlands, is that we have the doctors participate in the study. So this is not my idea of doing these types of study. This is a combined effort of the researchers' ideas and the doctors' ideas, and then we combine it together, because then the doctor can also stimulate patients that it's important to participate. So it's not the doctor who just invites them, but he or she also believes that it's important to have patients complete these questionnaires.
More questions? Oh, there's a hand over there. Catherine.
Thank you. I may have missed what you said, but did you say you used the cancer registry as a sampling frame to decide who to send the questionnaires to? Or do you collect the questionnaires from all patients and then use the sampling frame to sort of determine your individual research questions?
No, we start with the cancer registry as a sampling frame. So we select the patients based on the research question we have and the type of patients we would like to have to complete questionnaires. And then we go back to the different hospitals with a list of patient numbers and say, these are the patients in your hospital we would like to participate. And then it starts from there.
Oh, a comment out the back.
Lonica, of course, my compliments, but you didn't say that by doing these kind of studies, the patient groups are getting more and more involved, indeed, and that is not only means that you get better questionnaires, but also that they are increasingly involved in all sorts of funding organizations, and their opinion is asked. And that is, I think, also, so we broaden the financial basis also for the cancer registry indirectly this way.
Right.
So that is something to keep in mind. And that is, I think, very important for the future of cancer registries, because we need a lot of supporters in a lot of fields and not just our own program owners.
Any more questions? Okay. Can I ask you to thank Lonica again for that
Thank you.
excellent presentation?
So we will continue with session 7. I will introduce Dr. Christian Ehrmann. He's a research associate in Cancer Registry St. Gallo Penzel in East Switzerland. He holds a master's degree in mathematics and is completing a PhD in epidemiology at the University of Bern. Prior to this appointment, he had several years of working experience in data analysis and project management, including 2 years at the International Agency for Research on Cancer. So the title of the presentation is Rapid Increase of the Number of Cancer Survival in Eastern Switzerland. Dr. Ehrmann.
Thank you very much. And thank you very much indeed for giving us the opportunity to present our research here. So who are our cancer survivors? We work with the definition of the American Society of Clinical Oncology, those living with, through, and beyond cancer, equaling the definition of complete prevalence. They are a heterogeneous group, as you might know, and one subgroup has quite high demands on the health system, especially those with advanced cancers, while others more or less require intense follow-up due to the consequences of cancer itself and long-term effects of treatment. We realized that we know very little about them and about the numbers and the dynamics and their characteristics. And therefore, we aim to quantify the number of cancer survivors, the dynamics, and to know more about the change of their characteristics over time. And here we focused on the total number of cancer survivors because we aim to estimate the current and future needs to the health system. But the percentages are given as well to understand the magnitude. The gold standard for complete prevalence would be counting all registered persons still being alive. But this requires quite long registration, and we have only 30 years, which is little because we want to study trends. So the model-based approach uses the relationship of prevalence with incidence and survival. We applied the PIAMOD method with the data of the cancer registry, St. Gallen, Appenzell, and the Swiss Federal Statistical Office, and investigated all invasive malignancies, excluding for non-melanotic skin cancers. We used the joint point regression program by NCI to quantify the trends, and we analyzed the survivor characteristics with our own data. We knew that incidence and survival are increasing in our region and mortality decreasing. So we hypothesized an increase in the number of cancer survivors, and we verified that with a joint point analysis and showing an exponential increase in the number of cancer survivors in the absolute numbers and a piecewise linear increase in the rate of survivors. This is to say that the exponential increase is actually a combination of effects of population change as well as change in cancer indicators. The number of cancer survivors doubled in the time, 20 years, from 1990 to 2010. I think this goes in there very well. And I see gender differences in males and females, of males increasing much quicker in the moment with a current annual change of 4.6 compared to 3.1 in women. While the population increased by 13%, the number of cancer survivors doubled, and so the rate increased considerably by 74%, from 1.9% in of the population in 1990 to 3.4% survivors in the population in 2010. Now here you see the number of survivors according to time since diagnosis. The bars present the modeled estimates and the lines the results of the count method, and you see the fit of the model is pretty good for these. And the increase in the 1-year survivors is mainly due to the increase of newly diagnosed cancers, a result of more screening uptake in the region and the aging population. And in this group, most of them are still under active treatment. The biggest group is those in the phase between 1 and 5 years since diagnosis, where some of them are still under active treatment, like breast cancer, most breast cancer cases, and the others are in close follow-up in search of relapse. The biggest increase, however, is seen in the longer-term survivors, which is a consequence of better treatment and earlier diagnosis. When we now look at the cancer types of the survivors, we see that the biggest increase by far is in prostate cancer. It's about 4-fold increase, followed by melanoma and breast. All cancers where we observe increased diagnosis of new cases, but which have as such a favorable prognosis. But on the other hand, also cancers like lung cancer with an unfavorable prognosis increased as well. So this shows actually the complexity of the subject. And looking at the age of the survivors, we see that the highest increase is in those 50 to 69 years old. Again, here we also see the highest increase in incidence, and this is also the age group where typically screening takes place. Population-based screening started only in 2010 with breast. When we wanted to know the status of our registered survivors, we see that most of them had only one primary, 8% had multiple. And as a proxy for their current oncological needs of current oncological service, we investigated the state of the disease. And we see that 9% present the malignancy of the hematopoietic system, requiring very long-term oncological treatment. 5% were diagnosed with a synchronous metastatic disease, and 5% were originally diagnosed at early stage but have relapsed, and another 9% have only recently been diagnosed. So over a quarter of our survivors require intensive oncological care. As I said in the beginning, data, especially about dynamics, is scarce, but if we look at the published numbers of survivors in log scale on the left side, then we clearly see the exponential trend with about the same magnitude for all countries. And even more, we compared with the joint point our estimates and those published by the NORDCAN website, and we see that since 2002 there is no significant difference. For the projection, the US projected 31% increase in the number of cancer survivors from 2010 to 2020, compared to UK with 41%, and our estimates show 29.5% increase. So, in conclusion, the number of cancer survivors increased exponentially and very probably will do so in the next 10 years. And this is not only regional and a consequence of the growing population, population dynamics, aging, growing population, and cancer incidence, changed cancer incidence, survival, and mortality. And this asks for a global strategy to cope with increasing numbers and special characteristics of survivors. And finally, we need to know more about the needs of the survivors. What do they need for type of care? How many will actually go to long-term care? And also, how does this translate into number of oncologists, urologists, care personnel, training resources to adequately meet these needs? With this nice image, I would like to thank you for your attention.
Question to the presentation? Sabine.
Thank you for this nice presentation. I might have missed it, but how did you retrieve information on recurrence?
That's a very good question. Actually, this is very much due to the really enthusiastic registration team, I would say, first of all. And we know that only passively. Well, you know, I will go back here. Maybe this is of interest. This is the only number which might be at least a little bit underestimated. It might be towards 80% complete. And this is only registered in the recent years. So that's why we only presented here a status from the end of this period we investigated and not a time trend.
And what do you mean by this is passively gathered? Do you get the pathology reports from this from these relapses automatically, or?
Right. And
Okay,
if,
so
if there are
you-
more detailed questions, maybe you know, there's a real expert down there next to you, Sylvia S. She might give you details.
Well, it is not complete, certainly, but we search in the hospitals, list persons who have been registered before and now are presented with metastases, radio-oncologist services, so not only pathology reports. Pathology reports is only one of the but of course it is very difficult, but we have validated this data because now we are doing a study on metastatic breast cancer, and we are asking for every woman that has been diagnosed in a certain period if she has, and we would think it is about 80% complete, the information we have.
Okay, thank you. Only one question and then we will go to the next presentation.
Thank you for your presentation. I see that 92% of your cases has one primary, 8% they have a second primary. It's included the skin cancer, or it looks high?
No, this is excluding non-melanotic skin cancers. As you know, all the data I presented is excluding for non-melanotic skin cancers.
Thank you.
Thank you very much. The next presentation is Paul Hanley, Earls economist from National Cancer Registry, Ireland. The title is Lost Productivity Due to Colorectal Cancer, Pattern and Cost for Ireland.
Good afternoon. As mentioned, my name is Paul Hanley, and my presentation today is on lost productivity due to colorectal cancer, and I'll be looking at the patterns and costs for Ireland. Okay, I'd just like to start with a small bit of background before I get into the main results, and just talk to you a bit about where the actual research for this project is coming from. 5 years ago, the National Cancer Registry of Ireland were awarded funding to examine the economic costs of cancer in Ireland. Before this time, there wasn't a great deal of knowledge on what actually consisted of the costs that emanated from a diagnosis of colorectal cancer. So what we wanted to do is try and fill in some of these gaps. Now, there was some sketchy information in terms of the economic costs of diagnosis, and there was some information in terms of treatment. But what we would argue is that that's only one of the various perspectives you can look at when you're looking at the economic costs affiliated with any cancer type, and in particular colorectal cancer here. So what we wanted to do in our analysis was to expand the spectrum of known costs, expand it from the health service perspective, which there is some information out there on, to include one, and most importantly, the patient perspective. So to take into account, let's say, the travel costs that a patient incurs and any other costs that is incurred following a diagnosis of colorectal cancer. The primary goal of this presentation, however, is to expand the spectrum of costs even further and to concentrate on societal costs. Now, what I mean by societal costs emanating from colorectal cancer is linking a diagnosis of cancer to a person that is in a job at that time and who has to take time away from that job. So we'll be looking at the productivity losses that emanate from this absence from work. Now, to give you a bit of background then on the known knowledge in this area, basically there's not that much known in the area, or there wasn't that much up until very recently. So we know that a diagnosis of cancer is going to affect a working individual, individual, and we know that they'll have to take some time off work. Recently, the survivorship literature has delved into that black box and has brought up a couple of unique insights into that area. What they've found is that the period of absences for a diagnosis of cancer, and these generally come from breast cancer cases, is that people take from a few to many months off from work. So that was pretty straightforward. But what happens as well is that even though most cancer survivors return to work, a lot of them return on reduced hours. So they might have started off at a 40-hour week and they might reduce that down to a 20-hour week. And we try to examine what are the productivity implications of that. The third aspect of this research was that many of the cancer patients, a significant minority, do not return to the workforce after being diagnosed with cancer. So these are the ideas that came out of the survivorship literature, and what we wanted to try and do is translate that into economic terminology. So we take these ideas, and as most things in economics, we just add more complex terminology to a simple idea. So what we've done is we've used new terminology here in economics, and we've put in that these type of absences are called absenteeism or disability. So when I refer to disability, it just means an absence from work. And the different types, as we've seen already, they're temporary, there's ongoing reduced hours, and there's permanent workforce departure as well. Also, when it comes to the economic costs, we've added in an extra factor here, which is premature mortality. So we've also looked at the life years lost and tried to cost up this as well. So if you take all of that together, what you end up with is the total productivity costs for our particular cancer type, for colorectal cancer. Okay, so that's the theory, but how did we go about actually examining this on the ground? Well, what we did was we implemented a survey using the sampling frame from the National Cancer Registry, and we sent out a postal questionnaire to 1,273 survivors of colorectal cancer. From this, we received a response rate of 39%, and out of the 39%, or roughly 500 responses that we received, 159 of them were in paid work when they were diagnosed with cancer. We also used the registry to examine premature mortality as well. The type of data that we received from this questionnaire, as we've seen before, we asked people questions about temporary and permanent absences from work, and we also examined the premature mortality separately from the questionnaire. Now, we have then a stockpile of information on the absences or the time away from work, the time missed from work. What we have to do next to examine the economic costs is to value this time. And what's normally used in economics is this thing called a human capital approach. Now, the human capital approach, it's quite harsh, let's say, in that it views individuals as having a stock of productive capital. So it says, okay, let's say you start working at 20 years of age and you retire at 65. Your potential stock of working time is all the years between those 2 points. Anything then that impacts on that potential working time, such as a disease like cancer, we measure that time off and we value it as an approximation with the wage rate. So we say for the amount of time that was taken off, we apply the gender-adjusted and occupation-adjusted wage rate to that time, and we get an idea of the productivity cost to the economy. So when we take all this into account, what we end up with, and what you'll see next, is the total productivity costs. And importantly, this is per working patient. So it's not for the entire country of Ireland, it's per patient when any of these costs are shown in the next slides. Okay, so to move on to what we actually found then, the results, before looking at the costs themselves, I just want to highlight to you some of the patterns that we discovered in terms of the time lost from work following a diagnosis of colorectal cancer. Now, we decomposed these patterns of lost time into both males and females, and there's quite a bit of information up there. So I just wanted to highlight maybe a couple of things to you if I could. The first one is that Most of the cancer patients that responded to our survey took some time off work. So for males, 89% almost, and in the case of females, 93%. So most people, as you'd expect after a diagnosis of cancer, take some time off work. We have an indication then of how much time they took off work, which is in the male case about 26 weeks, in the female case nearly 25. So not much difference there between the male and female cases. We also see here that a significant minority of patients decided to leave the workforce permanently, and that has effects in terms of productivity, as we'll see in the next slide. Also, and really the only difference between males and females, was the percentage of time taken off in terms of returning to work, but working reduced hours when you return to work. So we saw the difference was that males, a lot more males, over 20%, came back to work but reduced the number of hours that they worked compared to females. So all these patterns of absence then, to these, we applied the human capital approach. So we applied the wage rate to this time taken off work. Okay, so when we applied this human capital approach, we discovered that the costs, particularly in the male and female case, were quite high. So again, we decompose them by male and female, but we also have a total costing here for per colorectal cancer patient. Again, if I could just highlight a couple of the points from it. One is, and these are the key drivers of the productivity costs in these cases, the key drivers are these reduced working hours. So it's for cancer patients, for survivors that return to work but work less hours. The cost for the male case is $82,000 per person when this is worked up over a lifetime, and for females it's nearly $70,000. So that's one of the key drivers of these productivity costs for the economy. The other key driver for the economy was the premature mortality cost, the amount of life lost. And when we costed up these, it came to $96,000 for the males and slightly less just due to the differences in wages for females. So overall then, the total productivity costs, and if I just concentrate on the bottom right one there, for a colorectal cancer patient is over €200,000. So when you take into account all these absences from work and you look at it from employers or from an economic perspective, they generate into substantial costs. So they're the totals we came out, and again, they're per person, so $205,000 per person. Okay, so those figures are fine, but what do they mean when you compare them to other figures and from other perspectives? Well, if we compare them to, let's say, figures that we've looked at previously for prostate cancer and for breast cancer, you can see the colorectal cancer, the productivity costs are relatively high. In fact, they're the highest of the three types that we've looked at. The prostate cancer costs were smaller at $109,000. They're similar to the breast cancer costs. If we expand that out even further and going back to the idea of the different perspectives, the different ways you can look at economic costs, if you compare these productivity costs to the direct health service costs, so how much does it cost to diagnose, treat and follow up an individual with colorectal cancer, recent research has shown that the cost for direct health services is roughly €40,000. So if you compare that perspective, the health service perspective, to the economic one or societal one of $200,000, you can see that these are substantial costs. When you compare them to what is known out there, they really are quite large and a multitude of what's known. The final point here is that a lot of economists, they can be blamed for being a bit pessimistic and a bit downtrodden, but if we flick this perspective around and we no longer look at it as costs, but we look at it as savings, what we can say is that these estimates here, this 205,000, it can also show the savings that can be garnered if we reduce cancer incidence and extend survival through, let's say, a population-based screening and identifying cancer earlier. So not just looking at them as costs, but as potential savings to the economy that can be engendered. Okay, so to sum up then, and to conclude, my first point, and I hope you took this from the presentation, is that the productivity costs that emanate from any cancer are quite large. In terms of colorectal cancer, 205,000 per person from our sample. Failure then to account for these productivity costs would lead to an underestimate if you're looking at costs from the broader societal perspective. So we think this should be integrated into a broader idea of economic costs. And thirdly, our next step is to take the estimates that we have, these productivity estimates. We also have patient estimates, so patient costs in terms of time and travel. You may have seen it in the posters over there. So we want to combine it with those and combine it with our health service costs as well to get a holistic cost for colorectal cancer in Ireland. So that's what we're trying to achieve in the coming year or so. And I'd just like to finish up by acknowledging a few people. I'd just like to thank the patients who filled in our questionnaires. Grateful to everyone who helped out in terms of inputting of the data. I'd like to thank the grant holders, the HRB, and thank you very much for listening as well. Thank you.
Thank you. There is the time for one question.
Thank you very much for a fascinating presentation. I'm curious, with that the human capital approach, it does put value to people who are retired and to people who stay home and are homemakers. Did you value that, or it sounded like you were just looking at the workforce contribution, but not the society?
That's a very good point. It really depends. The human capital approach, it can be used to measure people who are retired, homemakers, as you say. In this particular case, we've just concentrated on people that are working. But in other cases, and we are going to expand it out, we will probably, because what I didn't have really time to show here is that we've done a lot of sensitivity analysis on these results. So we can extend this out to include that as well. The only thing is, what we used here in terms of wages were in terms of occupation. So if you look at homemakers then, there's a lot of different ways that you can measure that time homemaking. You probably shouldn't measure it at zero. I would advocate that. But there is an issue then when you go to actually deriving or trying to estimate the time and trying to estimate a cost for that time. There's a whole range of different assumptions you can make and estimates you can do. And we can do that in sensitivity analysis, but we just wanted to keep it simple here and just concentrated on the working population, and that's what we had our wage data for. Okay.
Thank you. I know that there are probably other questions, but the time is running. Thank you again.
Thank you.
Okay, so we're now going to move to the final presentation in this section, and it's from Paolo Bailey. Paolo graduated in demographic statistics in 2001 with a thesis on Eurocare life table databases and specialised in health statistics in 2007. He's worked in epidemiology since 2001 and is at the Istituto Nazionale Tumori in Milan. And he's going to talk today about cancer rehabilitation indicators for Europe.
Thank you so much for giving me the possibility to present you one of the results of the EuroChip project. Today I will present you our suggestion for indicators on cancer rehabilitations, and I will give you many of the information that already other presenters before discussed. In fact, the European Commission, the history, in the last decade, the European Commission, and exactly the Directorate in Luxembourg on Public Health, subsidized a lot of projects to discuss about indicators, not only on cancer, of course, but on various diseases, and on the possibility to collect these indicators in all European member states. For example, thanks to the European Commission, Eurostat, and then various national statistic offices organized a common health interview service with similar questions across all member states in order to have, for example, comparable indicators on risk factors. So for cancer, of course, we are in a better position in respect of other diseases, thanks to the presence of cancer registries in the majority of member states in Europe. So in 2002-2003, the European Cancer Health Indicator Project organized various discussions among experts in Europe in order to suggest indicators on prevention, on screening, on care treatment, on epidemiological classical indicators. But in this list, something was completely missing, that is indicators on cancer rehabilitation. This is the reason why recently, last year more or less, and we defined with various colleagues in Europe, and we organized a work package led by Dr. Piret Virus in order to discuss and propose a list of possible indicators on cancer rehabilitation collectible across Europe with common methods and sources. We did not collect data. It's not our mandate to collect data. It's only to organize a group of experts to discuss about the possible indicators, which are the criteria that we followed to discuss about these indicators. First of all, they must be at population level, at an aggregated level, should be proxy of something. And another point, really important, is that member states could collect the indicator with similar methodologies and similar data sources. Regarding the relationship between these indicators and cancer registries, we more or less discussed about two objectives. The first one is to identify some indicators able to quantify the cancer rehabilitation border in Europe. And of course, main indications in this field are those referring to prevalence, total cancer prevalence, presented before by our colleague in Switzerland. Of course, this broad indicator includes also information on patients without rehabilitation needs. So we can focus also on 5-year cancer prevalence, 10-year cancer prevalence, merging the various prevalence by time, and also to enlarge and to evaluate the possibility to estimate statistically the proportion of non-cured patients using the long-term survival trends. At the end, of course, we also discussed the possibility to collect and to try to subdivide, to qualify the prevalence indicators by health status of cancer patients. We tried to define the indicators that we call the differentiated prevalence, and that is to subdivide prevalence by number of patients expected to die in 1 year that can have palliative care needs in principle, to die in more than 1 year that can have various types of rehabilitation needs, to survive with or without relapses. So regarding this first group of possible indicators, of course, total prevalence and 5-year prevalence and prevalence by time of diagnosis are available in Europe using in various cancer registries, for example, recently published by Rare Care for total prevalence. The proportion of cured and non-cured patients require a high modelization starting from trends of survival, and Eurocare 4 already performed this modelization and probably will perform also in Eurocare 5. Regarding the estimate of differentiated prevalence, we more or less can follow two different methods. One, performed in UK, is to link cancer registry data and prevalent cases in cancer registry with information coming, for example, for hospitalization. But this is quite complicated. It's really useful for a nation, but it's quite complicated to enlarge to other countries because these administrative data are not so comparable and homogeneous across Europe. So the idea could be to follow the experience of high-resolution studies also for prevalent cases and evaluate the status of prevalent patients, collecting detailed information on clinical and on treatment and clinical follow-up on a sample and for some sites. The other area that we discussed in our group was to try to identify some indicators on rehabilitation needs and their satisfaction. And this is really connected with the presentation on profiles registries. In order to collect this type of indicators, we define two different methods. The first one is to count rehabilitation services. What this means that, for example, we can focus on one specific rehabilitation service, like home assistance, and this service is offered by specific structure in our specific institute. So we can merge the list of patients receiving home assistance with the list of patients presented in a cancer registries. Of course, with this methodology, we can collect only information on satisfied rehabilitation needs and not on unmet needs. Also, this type of collection is really important for a nation, but it's quite complicated to replicate in other countries because the structure giving and offering rehabilitation services are really not comparable across countries. So the other method, if we want to collect information on rehabilitation needs, is to ask directly to cancer patients as performed by profiles. So we are speaking about possible health interview surveys to perform in various countries. But of course, to organize this type of studies, we need to focus on possible problems. No participation of cancer patients could false the population level of our indicator. Of course, as mentioned before, there are many limitations due to the confidentiality laws to interview directly the patients. And another main point to understand is that a cancer registry cannot directly contact the cancer patient, but needs to contact before the general practitioner or other type of clinician, because the patient may not be aware that he is or she is a cancer patient. So we need to have the authorization from a clinician or from a general practitioner. So in this topic, we defined two possible main indicators to be collected: return to work and quality of life. And we perform a similar literature research performed by Profiles and by Eurocurs in order to find if there are some examples replicable in Europe. For return to work, we performed this literature research more or less in January this year, and we found some example not completely replicable in Europe because there is the connection between cancer registries and specific national databases, and other experiences like those presented before me. And regarding quality of life, also we identified more or less 45 papers in Europe, mainly as shown before in Netherlands, Denmark, Sweden and France, using various types of questionnaire, and the level of participation of cancer patients varies from 32 to 94%, with an average of 72% in our 45 papers. So these are, of course, Eurochip perform an intellectual work to discuss about cancer experts, cancer rehabilitation experts, the possibility to have in future some information able to compare rehabilitation. So at the present, indicators of prevalence are available and can be, also cured prevalence can be updated with Eurocare 5. And also indicators on that we call differentiated prevalence can be organized following the experience of high-resolution studies on prevalent cases. And at the same time, it's really important that Eurochip give this information to the European Commission. Now it's not possible to think about to collect in a comparable way quality of life, return to work in a short term, but it's really important to perform research on this field and to start to collect this information, also to enlarge the possibility to follow the profile approach, because in our opinion it's really important not only to have data, but to use data for the population covered by cancer registries. And as Dr. Lonneke van der Pol shows before, profiles has a direct impact on the population of the cancer registry. Thank you. Now, of course, this is the list of participants that I thank you very much in the group.
Okay. Take questions. Hands down at the front here.
Thank you for making this clear presentation about the list of proposed items to collect. I'm just wondering, what is your definition of rehabilitation?
Yeah, we use the definition of WHO, including physical, psychosocial, psychological, social rehabilitation, all together.
Yeah, because I was a bit confused because you had home aid as one of the things that you want to collect. And to me, that seems to be more into care and to perhaps the palliation part. Whereas the other part was that you said return to work. And of course, that applies only to a part of the cancer patients. There's somebody that returns to home, but to normal domestic duties. Is that what you mean by assistance by home service, or what?
No, we discussed about the possibility to collect both, but we discussed on a long list of possible indicators, and at the end we focus on return to work and quality of life regarding the needs. We also discussed about the possibility to collect information on home assistance and regarding palliative care indicators. We didn't discuss a lot because it's another topic.
Yeah, we agree that's another topic than the rehabilitation.
Yeah.
Did your big group agree on the definitions? Be honest,
so, regarding the quality of life return to work, as I wrote here, there are many other. It's necessary to increase the research and to define exactly the definition. So we did not reach a complete agreement. We agree to focus on these two topics in the future. It's really important that the European Commission would like organize projects on this topic also to collect indicators in a comparable way. Regarding the prevalence, of course, yes, and also differentiated prevalence, we discussed and we propose possible methods, and two possible methods. To combine cancer registries data with the hospital data, like performed in UK, or to organize similar high-resolution studies on prevalent cases.
Now the most difficult question. We are here an assembly of people that are used to collect data, and you're also proposing to collect data. Could you just lift the curtain a little? What do you see in the future? What are we going to do to assist it, and how can we use these indicators for what you foresee we should do in the future?
My idea is that cancer registries need to collect other data for their population. And one, you can focus on treatment, you can focus on screening, but also you can focus on these topics like profiles. And in my view, if a cancer registry would like to focus on patients' needs, they will have a strict impact to the population, because this information are not so common, and clinician can be interested, and not only patient, but also clinician can be interested on quality of life and so on. This is my idea.
So the quality of life, I agree, the clinicians are interested in that.
Yeah, but also,
we also have to be pragmatic in terms of how many variables are we going to collect in cancer registries and try to get the core variables right.
I think that one cancer registry should stress on one topic and to decide which is the topic on which we would like to collect many data.
Thank you, Paolo.
Are there any more questions? One over here.
Actually, a couple of quick questions. Okay. Again, back to the rehabilitation index. You know, there are a wealthy of studies pointing out that interview the patient is not the only way you can compute that, but you can go to the caregivers, you can go to the family, and so on. So if you consider this range of a different type of indexes. And the other question was, how did you decide that some of the indicators were not applicable to Europe? Did you use, since it's a very big group, did you use Delphi method, consensus method, other type of agreement methods to come up with decision? Thank you.
Okay. Regarding the second question, we do not perform a Delphi method. We did a survey and we collected with a specific question on one indicator to another indicator, on possible collection of one indicator to another, and we did a survey among experts across Europe, but one or two experts in each country. And we defined that it's not possible to have comparable data on different structures. In fact, for example, some countries have hospices, some countries do not have hospices, some countries have home assistant, others no. So it's really complicated at this stage to have a comparable proxy to compare one type of rehabilitation service across Europe.
Oh, one final question over there, then we'll wrap up.
Thanks. This is sort of linked to the earlier talk as well. Do you think there's ever likely to be an appetite to try and collect a core set of problems from all cancer patients rather than just focusing on specific research questions?
Could you repeat, please?
Sorry about that. Do you think there's ever going to be a desire to collect a core set of patient-reported outcome measures from all cancer patients using the basis of a cancer registry, rather than just specifically targeting sort of certain research questions?
Tutti su campioni o su tutti, praticamente? I think that it's possible to perform, it's realistic to perform on sample, these studies. It's Profile probably can collect information on all cancer patients with the specific characteristic, but in other cancer registries, it's possible to perform this type of study on representative samples.
Thank you.
Okay, thanks very much, Paolo. Okay, we're going to make a slight change to the programme now because we're running a little bit late. We're going to break for coffee, and then can people please be back here promptly at 4:15 because we're going to do the presentation of honorary membership then. Okay.
Now.